So I've been charged with changing the venue from benign heme to malignant heme. And with that, I was asked to review the new monoclonal antibodies, which is really changing the way we approach patients with relapsed acute lymphoblastic leukemia. The case in the ARS question that David had asked was a real patient of mine who I had seen as a freshman before he started at the University of Vermont, and then unfortunately just about a month before he finished his 2 years of prolonged maintenance therapy had relapsed, and the questions that were posed to me is what to do next that you guys had already answered. But moving on, this is the problem. So this is the data that's been published with relapsed acute lymphoblastic leukemia. This was taken, there are many examples, but this is my favorite curves from a large publication from the ECOG 2993 study, which was a large randomized study that took over about 13 years to ask a question about transplant versus no transplant. But that's not the point of the slide. The point of the slide is what happened to those patients who had refractory leukemia or relapsed. And there was a large number of patients on the study, therefore there was a large number of patients who relapsed. And the authors asked the question, well, what happened? Regardless of how they were treated, they were all treated with induction. This was a young population. And then a myriad of patients got consolidated with chemo, autologous transplant, or an allogeneic transplant. And regardless of how they were consolidated, the results are very, very dismal and poor, arguing that there really is no salvage, or there has historically been no salvage for patients with relapsed acute lymphoblastic leukemia. And so there's clearly an unmet need, and that's what my talk is going to focus on. So lots of chemotherapeutic options, but we're going to move into some immunotherapeutic options. These are some of the monoclonal antibodies and their targets. The ones highlighted in red is the ones that I'm going to focus on for the sake of time. So first we're going to talk about CD19. CD19 is basically ubiquitously expressed in B-cell ALL. It's internalized upon antibody binding. It's not shed into the extracellular environment, a very important quality for a target, because if it's shed, it's going to soak up the antibody. And there's a variety of agents that have been developed. The one I'm going to focus on is M2M Ab that was approved a couple years ago. But there are other antibodies for this target that are in clinical development. So this is the bispecific antibody. It's a relatively novel approach. There was a company, Meditech in Germany, or Micromet in Germany, that took about a decade and a half to try and develop this. It's not a trivial issue. You take the business end of one antibody against the target, CD19, and you take the business end of another target, in this case CD3, which is going to bind to the person's own T cells, or in a patient post-transplant, the donor T cells, irrespective, doesn't make any difference. Then you have to configure these molecules in such a way that they're not excluding each other, so that you can bring the T cell at just the right level to the target to activate the T cell. And in this immunotherapeutic approach, what you're doing is you're stimulating the patient's T cells, whether the own T cells or his donor T cells from a prior transplant, to now go and kill the tumor cells, the lymphoblasts of the disease. And so this is the bispecific approach that Micromet and now Amgen have patented and then have taken it to study. So there was a series of very, very small proof of concept studies published in Science or in clinical journals, about 10 or 20 patients. But this led to this large phase 2 international multicenter study that we all participated in. And this was using M2M Ab as a fixed continuous infusion for 4 weeks with a 2-week break. So not a logistically trivial approach. And during these 4 weeks of therapy, I'll tell you that the patients have a significant amount of potential toxicities, including cytokine reactivation syndrome with fevers, hypotension, and neurologic sequelae, which can include just some minor tremors to encephalopathy or seizures. Patients proceed on to the 4 weeks, and then if they have a response, then they can get subsequent cycles. And so this is a large phase 2 study that was published by Max Top and colleagues in the Lancet Oncology a couple years ago. And this is the data, 43% overall response rate, including 33% of patients who achieved a complete remission, meaning no blasts, normal blood counts, CRHs, no blasts, and incomplete recovery of either neutrophils and or platelets, different from the CRI that those of us who report on, so a slightly different and lower bar. And then there were some patients who had a leukemia-free state, and then of course there were patients who didn't respond. But of those patients who had a response, about 3/4 of them to 4/5 of them, 80%, achieved what we call the minimal residual disease status. That is, that their level of detection of their tumor was below the level of one cancer cell or one lymphoblast out of 10,000. And that's been associated, at least with de novo leukemia, as having a good prognosis. So this led to the FDA approval of this agent for patients with B-cell relapsed acute lymphoblastic leukemia. The studies have been done in Europe as well, looking at earlier relapses, looking at relapses for minimal residual disease alone. So these patients are still in morphologic remission, but they have a detectable leukemia clone. And Nicola Budget from the German Jamal study presented this at ASH a couple years ago, again looking at this 4-week continuous infusion, followed by a 2-week break, and then continuing. The goal of this study was to get patients to transplant, but you can see a very, very high ability to get patients and convert them from MRD positive to MRD negative, and then the Kaplan-Meier curves looking for the results in terms of the durability of this approach. Again, compare and contrast this to the first slide I showed you in terms of the outcome. This is one of the approaches that our institution has taken for patients who have persistent disease, albeit at the MRD level. So, of course, when you have studies that look at phase 2 approaches for relapse disease, you want to take this into a phase 3 setting. It was difficult in the United States to pursue this study. In fact, most of us closed it because the control arm now was approved. So it kind of defeated the purpose. But this study was done outside of the United States and North America and mostly in Europe. And this was a phase 3 study looking at first and second relapse with B-cell acute lymphoblastic leukemia, Philadelphia negative. An important point, Philadelphia negative only. And these patients were randomized in a 2-to-1 strata comparing blinatumomab to standard of care chemotherapy in a cocktail, which is listed over here in the orange bar, of high-dose Ara-C containing regimens. What you and I would do all the time was in comparison. And patients got, again, this fixed dose 4-week infusion, followed by a 2-week rest, and then continued consolidations if patients couldn't go to transplant. This is the hematologic response, showing in gray the patients who were randomized to blinatumomab versus those in orange or yellow or whatever, well, it's a different color there than here, so I am not colorblind, but a different color in patients randomized to the standard of care arm. And if you look at the overall response or the complete remission rates, they were far in excess with a strong p-value of less than 0.001 in favor of the experimental arm, that is the blinatumomab. And furthermore, if you look at the molecular remission, which I think is an important endpoint prior to giving confidence going into a second transplant or a first transplant and salvage, there was a huge benefit in terms of those patients who achieved a CR and received blinatumomab versus those patients who achieved a CR and had received the standard of care chemotherapy in favor of blinatumomab. And if one looks at the Kaplan-Meier overall survival curve, you can see here that the median overall survival was 7.5 months versus 4 months. Clearly not a home run. We need better improvements in terms of getting our patients to second transplant, number one. And number two, one of the limitations of this, and you'll see in the next study, is the high transplant-related morbidity and mortality with ALL, specifically in CR2 or higher. But nevertheless, this was now demonstrated, and so blinatumomab will likely achieve full approval by the FDA based on this phase 3 data. And it's taken up front, so when you have a drug that works out back, so to speak, in relapse refractory setting. It's important to move it up front. There are many trials. This is the one that is ongoing at our institution and others. It's a cooperative group led by ECOG. Mark Litzau is the primary investigator, and this is taking a backbone of induction therapy for adult patients 30 to 65 and asking the question whether 2 cycles of blinatumomab in remission can improve the overall outcome. The idea is that you're going to get deeper remissions to those patients randomized to blinatumomab and therefore improve the outcome, regardless if patients are destined to transplant or not. So this is an exciting study that we're all actively accruing to. So for the second half of my talk, I'll focus on the other monoclonal antibody that we've been important in developing. CD22 is the target. Similar to CD19, CD22 is almost ubiquitously expressed on B-cell ALL. CD19 virtually 100%, CD22 about 90 to 95%. Again, it is internalized upon antibody binding. It is not shed into the environment, making it an appropriate target, and there are many antibodies in development. Iprituximab Ab is a naked antibody. InaTwosome Ab is an antibody-drug conjugate, and there are others. I'm going to focus on InaTwosome Ab given the time limitations. InaTwosome Ab is a classic antibody-drug conjugate with a monoclonal humanized antibody against CD22 with an adaptive linker attached to calicheamycin, which is the payload. Calicheamycin is a powerful anti-tumor agent. It was attached to another drug that you may remember called M2M Ab or Mylotarg, which may be coming back. But this is a drug against ALL and CD22. Just like most monoclonal antibody drug conjugates, again, it binds to the surface, internalized. It's due to acid in the acid membrane in the lysosome. It is destroyed, and then the calicheamycin is released from the antibody and is allowed to go into the nucleus, intercalate DNA, and cause apoptosis in responding patients. So there were several phase 2 studies at MD Anderson. The first one took a lymphoma-like regimen where the InaTwosome Ab also being tested in diffuse large B-cell and low-grade lymphomas on an every 3 or 4 week basis, like you would treat a patient with lymphoma. There was some elevation liver function tests in that particular trial, and then there were at the same time, a phase 2 study at MD Anderson looking at a weekly schedule, as well as a large industry-sponsored multi-center study, phase 1, trying to re-look at what the appropriate dose was on a weekly schedule. And so in a tabular form, I've put them all here, showing that the response rate, regardless of who was doing the study, either MD Anderson or single institution or the multi-institution sponsor-led trial, the responses were in the 60 to 70% range, and the weekly regimen seemed to be more tolerable with less toxicity. Anjali Advani also looked at a sub-cohort in advanced patients with salvage 2 or higher, showing very similar efficacy. And similar to the blinatumomab, these were deep remissions. These are remissions that, for most patients, achieved an MRD negative status. And so here you look at from the study that we presented at the DFCI that the vast majority of the patients who went into remission actually went into a MRD negative status. This is by a central lab at University of Washington in Seattle looking at 10 multicolor flow analysis, and 86% of the whole cohort of patients who achieved a remission actually achieved an MRD negative status. So this led to a randomized phase 3 study, the Innovate study. This was a 1-to-1 randomized study. This did include Philadelphia positive patients. About a quarter of the patients were pH positive. Patients were stratified based on duration of remission, 12 months more, 12 months less, age, as well as salvage 2 versus salvage 1. And similar to the Tower study, patients were randomized to receive either the investigational agent, which in this case was InaTwosome Ab, or dealer's choice, which was a high-dose Ara-C containing regimen, drugs that we, and recipes that we all are familiar with. This was presented a couple years ago, looking at the response criteria, which is the answer to one of the questions that was asked. So the overall response was 80% compared to the standard of care arm, which was 30%, with a highly statistical significant p-value. More importantly, or maybe equally important, of those patients who were in remission, of the 80% who got in remission, 80% of those achieved an MRD negative status compared to only 28% of the 33% of patients who went into remission who were randomized to the standard of care. So a huge sway in terms of the response, leading to almost a greater than 4 times improvement or increase in the number of patients who were eligible to go to transplant, either first transplant or second or greater transplant, depending on the case. And if you look at the stratification factors, whether this was based on age, based on duration of remission, or based on salvage, it all was in favor of the experimental arm. This is the duration of remission. In the darker color, the InaTwosome Ab randomized patients to the standard of care. Of course, it's almost a 3-to-1 in terms of that, just because of the increased remission, but nevertheless, it was statistically significant. And if you look at the progression-free survival again, the interesting here in the overall survival, although there was statistical significant improvement in the median, really I think one needs to look at the 2-year and 3-year survival in the plateau. Remember that 4 times as many patients went to transplant in the InaTwosome Ab arm, and there was almost a 40% transplant-related morbidity, which was also shown in the other studies. But it's the reality of doing business in a transplantable disease. One of the issues was veno-occlusive disease. Veno-occlusive disease was first appeared its ugly head in the Mylotarg era, and we did see it here. Remember, these patients are heavily pretreated, so we do see veno-occlusive disease at baseline. The risk factors were, in addition to age, whether these patients had second transplant, so they had a first transplant, then relapsing, went to a second transplant that increased the risk, and the conditioning regimen, a double alkylating regimen. Almost all the patients had a double alkylating approach, for which we don't usually use in our own institution, but it's important to, if you're going to use this agent, that there needs to be a close relationship with your transplant. If the transplanter is not in your institution, it needs to have a close discussion to make sure the transplanter who you're going to be referring the patient to knows the situation and knows that there is an issue or could be an issue with the conditioning regimen that he or she chooses to administer to their patient. So similar to the blinatumomab story, once a drug is effective in the relapse setting, I think it's important to try and play with it. The idea with monoclonal antibody drug conjugates, as you all know, is they're easily adaptive to chemotherapy regimens. So this is a recipe from MD Anderson looking at many hyper-CVD. We all know hyper-CVAD. This is a reduction in that regimen where the anthracycline has been removed and the doses of cyclophosphamide, dexamethasone, methotrexate, and cytarabine have been reduced, and you can see the reduction here. This has been a platform that other agents have been added to, so Elias Jabbour and his colleagues from MD Anderson should be applauded for looking at this type of a recipe and then adding novel agents. The novel agent here is InaTwosome Ab, and what they were able to show is improvements in progression-free and overall survival without any added toxicity. And then they looked at this approach, the same recipe I just showed you, in elderly untreated ALL, again, moving this closer and closer into the patient population that we want to cure. Elderly patients with ALL is, our big issue. We always pray for a Philadelphia chromosome because at least we have a target. For those patients who don't have a Philadelphia chromosome, there's really no good choice. So these are these elderly patients who are getting this mini hyper-CVD with InaTwosome Ab, again, no anthracycline. And the overall response rate that the MD Anderson reported at ASH this year was 98%. And here's the remission duration and overall survival curves. So this has led us to propose an intergroup trial that is just got approved finally by CTEP last week. And this is a trial looking at Wendy Stock's CLGB 10403, for which the patient that I presented, the real patient, had participated in. And so this is an ALL pediatric regimen that has been adapted into adults, and we're asking the question, can the addition of a novel antibody improve the outcome, looking at improving MRD negative rates, and therefore hopefully improving by decreasing the relapse rate, improving the overall survival. The idea of moving it up very close is most of these patients are not going to get transplanted because these are young patients, and most of them have normal cytogenetics, and so we hope not to see any of the hepatotoxicities that was seen in the relapse refractory trials. So in conclusion, I think we're luxury of riches finally in the ALL setting. I haven't talked to you about CAR T-cell therapy. That's going to be probably focused in the pediatric realm while the toxicities work out. But I think that what's going to be available to you and what is available to folks now for their B-cell relapsed ALL are these monoclonal antibodies, InaTwosome Ab approved, likely to get full approval, very high single-agent MRD negative rates. The toxicities are different. InaTwosome Ab has the cytokine release and neurologic toxicity, where InaTwosome Ab has thrombocytopenia, liver function abnormalities, and VOD. Both randomized phase 3 studies against standard of care were positive. InaTwosome Ab is at the FDA now. InaTwosome Ab already got approved. And there's two intergroup cooperative group studies led by CTEP, one in upfront patients, adult patients 30 to 55, and or 65, I'm sorry, and the other one led by the Alliance, which will be for the AYA young adult population. I just want to take a moment to thank my colleagues, including David at the Dana-Farber, and happy to answer any questions. Thank you.